Bismillahirrahmanirrahim. Assalamu alaikum. We have CT examination of the paranasal sinuses. This is axial, and here we have coronal reconstruction of paranasal sinuses. We can see lobulated polypoidal pathological soft tissue involving left side of the nasal cavity, left maxillary sinus, left ethmoid air cells, sphenoid sinus, and left frontal sinus. We can also see lamulated, punctate, and diffuse calcification or high density component in the lesion. Basically, it is a case of nasosinus polyposis with superadded fungal infection. High density component sports fungal infection because it contains proteinaceous material, calcium and manganese. Now we can see major component of the disease lies in left half of the nasal cavity, and we can also see there is ballooning of ethmoid air cells with loss of normal lamina peprici on left side. We can also see that nasal turbinates are stretched and distorted, eroded as well because of aggressive nature of disease process. We can see that cribriform plates are intact, and there is involvement of sphenoid sinus. Here there is focal area of erosion of left lateral bony boundary of sphenoid sinus. Similarly, we can see that part of the disease extends from posterior wall of the sphenoid sinus, eroding upper clivus, extends into prepontine cistern where it abuts with basilar artery. There is mass effect on nasal septum, which is deviated toward left side. So this is a case of aggressive nasosinus polyposis with superadded fungal infection. On axial images, we can see indistinct left lamina peprici, and this is bulging of left ethmoid air cell because of prominent component of the disease. Mass effect is also appreciated on medial rectus. You can compare it with the right-sided medial rectus muscle. Optic nerves are normal on either side. Overall, there is no gross abnormality in retroorbital fat. Medial rectus, inferior, and lateral recti appears unremarkable on both sides. We can also see paranasal sinuses on MRI. Here we have T2 axial and flare axial sequences, and here we have T1 and T2 coronal sequences. We can clearly appreciate there is ballooning of ethmoid air cell because of a disease component in it, but we can clearly appreciate that medial rectus shows normal signals with normal surrounding fat planes. Similarly, low signal intensity shows proteinaceous component and calcification with manganese, which are paramagnetic, and shows low signals are hypointense on fluid weighted sequences, and this can be confirmed on coronal T2 weighted sequence as well. And this is the area of clivus and posterior bony boundary of sphenoid sinus where disease causes focal erosion. However, basilar artery is patent and shows normal signal void flow in it. Overall, we can see cavernous sinus areas are normal, and there is no abnormality in brain parenchyma. Ventricular chain, brain stem, CP angles, cerebellum, and 7th, 8th nerve complexes appears unremarkable. So we have seen both CT and MR of aggressive nasosinus polyposis with superadded fungal infection. So whenever we suspect any fungal infection or aggressive nasosinus polyposis or tumor, it is mandatory for the radiologist to rule out involvement of adjacent structures, that is orbits, cavernous sinus areas, or brain, and we have to mention the status of the bony boundaries, especially cribriform plates, lamina peprici, and boundaries of sphenoid sinuses. Thank you. Assalamu alaikum.